All right, my name is Anna Tressiter. I'm the program director and assistant professor for the Master's of Public Health program here at Eastern Washington University. And we started this Grand Round series. This is our third one now, which we're very excited about, in order to help bring public health to everyone, especially to Spokane campus and all of our programs here. Public health is very much a part of all of our lives every day, from the moment we wake up to the moment we go to sleep. And it affects our ability to be able to provide great care, our ability to take care of ourselves and our communities, and to care for one another out there every day. So we have schedules. We have the series will go on all year for the school year, so feel free to make sure you pick one up. Next month we'll have maternal mortality as our subject of focus. A little bit more on that at the end. There we go. So today we're going to talk about suicide and suicide prevention, and this is certainly not news to probably anyone in the room. It's been all over the place. It's hard. We just got done with Suicide Prevention and Awareness Month, and it's an issue that's really touching so many lives in so many different ways. And so our speaker today will talk more about these statistics, but I did want to point this out right off the top that in Washington, suicide is the second leading cause of death for between the ages of 15 and 34. And this is one of the areas here in Spokane where Spokane deviates from the national average as well. Our population here between the ages of 15 and 34 is particularly at risk, much more so than the national average. And so this is why we really wanted to bring this issue up and have a chance to talk about it with you all today. Another reason why I wanted to bring this up is we do work on a campus of health professions. And you don't have to look very far on this campus to find people who are stressed out, burned out, possibly in need of some mental health assistance. And it's not unique to this campus. It's mental health in health professions in general is a huge issue. We're burned out, we're stressed out, and unfortunately we're seeing skyrocketing suicide rates of medical students, nursing students, and health professionals. In particular of female physicians, where you can see almost 130% increase in the incidence of female suicide of physicians, according to the, compared against the national average. So this is an issue that not only, we need to keep an eye on each other, make sure that we're bringing these community resources, not just to our patients and those we're caring for, but also thinking about our larger community here on the Spokane campus and make sure we're caring for each other. And all of these slides will be made available, so you can look at these closer. Okay, just another slide that examples this change in suicide rates. You can see Nevada is the only one who's actually had a decrease in the incidence of suicide over the last 15 years. Just more evidence on why we need to start thinking about, maybe changing the way we think about suicide and suicide prevention. And one of the things, we hear a lot of stats, as I just rattled off a few, but when we calculate suicide, we're talking about those who have completed suicide. That doesn't account for all the attempts in the ER visits and those who have had ideation. When you begin to factor in all of those statistics, it's a much more widespread problem than just the suicide statistics alone will indicate. So today we have a wonderful speaker for you from our MSW program here at Eastern, Stacy Che, who's the program director for the MSW hybrid program. She's worked in mental health for more than 20 years and provides suicide prevention training and education to healthcare professionals and community member in several states. She's a great resource on this, and so please make sure you're taking note of your questions, as we will have time for discussion and further questions at the end. So without further ado, oh, I'm sorry, one last housekeeping thing. It's the most important thing, how to ask questions. You all have little microphones in front of you, and there's a button that says push. Don't push it. Not yet, not yet. What'll happen is when you push that button, the camera will zoom to you, and you will be the focus of attention. So don't push that button unless you're ready. But what will happen when you're ready to ask a question, you push the button, and you hold it and you ask your question and then you let go and the camera will come back to us. Do we think we can handle that? I don't know, this group back here, I'm not so sure about right now, but so when you're ready for questions, that's how we can do it. That way your microphone also come on so that we have folks on webinar, so they'll be able to hear your question as well. And so hold it till you're done asking your question, then let go. Got it? All right, so without further ado, Stacy Che.
Hello to those of you that are watching this online. I'm a wanderer, so I'm probably not going to stay right here so you can see me. I want you to focus on the slides anyway. So several of you, I think, have been to presentations I've given before, so thank you for coming back and listening to more. For those of you who have come to the last couple of grand rounds, I do things a little bit differently. I try to get a little bit of audience participation because this is an incredibly intimate subject. It's not an easy conversation to have, so I'm actually a little glad that we got moved from that big auditorium because this actually offers a little bit more intimate setting. So the first thing I want to talk to you about is how we talk about suicide, because language matters. Okay, so this is your first piece of participation with me. How do we talk about suicide in our culture? Specifically, what type of words do you hear used by the media when describing a suicide? Committed. Yeah, we hear that word used over and over and over again. That is not a word we should be using, and actually the CDC and the World Health Organization has said for going on over 15 years now that we need to stop using the word committed and other terms specifically, which I'll talk about in a minute. But why wouldn't we use the word committed? What connotations, negative connotations, does the term committed have in our culture? Yes. Right, that people commit crimes. What else do we commit in our culture? In my world of mental health, we commit people involuntarily to the psychiatric units. Yep. There's one more big one, and it often overlaps with crime. Yes. Yeah, and murder is also called depending on your spiritual beliefs, a sin, yes. So the CDC and the World Health Organization has said stop using the term committed because we do have these really profound negative connotations that, suicide is a sin, suicide is a crime, and we really need to stop using those words because folks who are suicidal already feel stigma and shame. We want them to be able to come talk to us. Yeah, it's just, again, discouraged because it connotes the equivalent of a crime or a sin. We also don't want to hear the term completed suicide, because one, that's redundant because suicide is death, right? And completed seems benign, but this is not something that we want anybody to complete. We also hear the term successful. Somebody successfully committed suicide. It's absolutely not something that we consider successful. And then something that a lot of people don't really think about is when we're talking to somebody and we say, so you just had a failed suicide attempt. Think about that. What that language of failed attempt might transmit to the person who is feeling suicidal. Like, you're already struggling with how to stay alive, and now this is one more thing that somebody's saying I failed at. So we need to stop using those terms. Really, the best thing to say is died by suicide, death by suicide. When we're talking about attempts, it's like, we're so glad you survived your attempt. That is the way we need to have this conversation. Okay. So I do want to talk about suicide as a crime for a minute. Is suicide illegal? Is it a crime? What do you guys think? Okay, so I'm getting some yeses from here, and I'm getting some head shaking back there. Oh, and a wave over here. Okay, so suicide is not illegal. It has not been illegal since the early 80s. And if you think about this for a minute, how would you prosecute somebody who died by suicide? So that literally makes no sense. Oftentimes people confuse the fact that life insurance policies won't pay out for the first 2 years. Like, well, if life insurance won't pay, then it must be illegal. That, in fact, is not true. So none of our states have laws against dying by suicide. What we do have laws against are assisting somebody in the process of dying by suicide, unless you happen to live in one of those, I think we're up to 8 states that have death with dignity or assisted suicide or physician aid in dying. Although I will tell you that proponents of death with dignity absolutely do not want the word suicide attached to that behavior. Okay. So suicide is not a crime, it is a public health issue. I had a student in one of my classes, I think it was about 4 years ago, who said, "Why does the CDC keep track of folks who die by suicide?" Well, they keep track of it because they keep track of mortality and causes of death, and suicide is in fact causes of death. Thankfully, we live in a state that's been really proactive in creating policies specifically for health professionals and for schools to get training. So we've adapted laws to increase skills that are essential to suicide prevention and behavioral health and healthcare, and again, school settings, people who are in key positions to help identify risk and then work on prevention. So in 2016, we had a little over 1,000 Washington State residents die by suicide, and more than 1/5 of those were by veterans. So if you are going to be providing healthcare or any type of services to veterans, just know that they are a population that is an increased risk. And I don't have this in my slides, but I will share it now, that Native Americans and Alaska Natives actually have the highest suicide rates of any ethnic group. And we have several reservations in Indigenous folks who live in Washington State. So these are 2 things that actually make Washington State's suicide rates higher than the national average. And suicide is actually more common in rural than urban areas. So Stevens County, I don't know if I included that data, has a suicide rate of about 23.5 per 100,000, and Washington State is right around 15 per 100,000. Just curious if any of you are familiar with the legislation that's been passed in Washington State around suicide education and healthcare professionals. Really, nobody. Okay. So we actually passed our first legislation back in 2012. It was called the Matt Adler Suicide Assessment, Treatment, and Management Law. I'm going to tell you a little bit about Matt Adler for a minute, because quite frankly, he is all of us. He could be anybody sitting in this room. Matt Adler was a gentleman in his early 40s, again in the Seattle area, a successful attorney. His wife works for the VA medical system with 2 young children. And he died by suicide. And of course, his wife started to ask questions after that happened. What was going on with my husband that this is the choice he would make given what our lives looked like? And he was experiencing some depression, he was experiencing some anxiety, and he went to see his medical provider, as most people in this room would, okay? And he was put on some medication, and then he was referred to therapy through his private insurance. And even though we have mental health parity, oftentimes those of us who have private health insurance get maybe 6 to 10 sessions, depending on what our issue is. He'd actually been in treatment for about 2 years. And what his wife found out is that during his entire course of treatment, nobody asked him if he was suicidal. Not a single person. So grassroots advocacy on her part was, this should never happen to another human being. Anybody who works with people in the professional sector should be able to ask the question. And if the answer is yes, how do we get help? And in this first iteration of the law, people who have to have 6 hours of training every 6 years in order to maintain their license in Washington State are social workers, licensed marriage and family therapists, LMHCs, CDPs, and occupational therapists and psychologists. Okay, that's pretty comprehensive. Who's missing? Doctors and nurses, again, who most of us would see. Most of us don't have Medicaid and are not in publicly funded mental health services. So while they were then doing, grassroots advocacy to have another policy put in place, so you can see that we did get an amendment that all doctors and nurses practicing in Washington State do have to have this education. They do have to have 6 hours once in their entire career to maintain their license. The interesting thing is this legislation doesn't say what they have to do with that education. So they have the education. It doesn't mean now that they then also have to ask the question in their practice. In between this first law being passed and this law being passed, we also had a bill passed about what schools need to be doing. And this legislation says schools have to have 3 hours of mandatory training every single year about behavioral issues up to and including suicidal ideation. So we have some pending legislation that is going to impact higher education, and it would create a handful of suicide prevention resources that any college campus can use at any time, including crisis plans, gatekeeper training, and promotional materials. The nice thing is they're really focusing on colleges like 2-year and technical colleges, because those folks actually have higher suicide rates than people who attend 4-year institutions. So we'll see if we are able to get this passed. This is the second attempt to get this passed. Do you guys have any idea what happened in the last year that might have prompted more push to have this legislation? I see a head shaking back there. It was the death of the WSU quarterback that really drew attention to this. I would like to share with you that we had an EWU student die by suicide exactly a week after Tyler died, and nobody has heard of that. Most people who attend EWU are not aware that that death happened. So I appreciate that Tyler's family has wanted to talk about it, because it has brought a lot of awareness to a group of folks who do have higher suicide rates than the average population. In January of 2018, we, Spokane specifically, and this was started by the Human Rights Commission, created a Spokane Prevention Task Force. They're just getting started with their work. And this was in response to the medical examiners seeing an upward trend of suicide in Spokane, unfortunately. So not only were the number of suicides up, but there were more and more young men between the ages of 20 and 29 that were taking their own lives. So for anybody who does this work, even on a semi-regular basis, we're always taught to screen older folks, like 65 and older, men specifically, for suicide because they're at incredibly high risk. So 75 and older men, their rate is actually 38.8 per 100,000. So you can see that it's pretty significant for them. And Dr. Tressiter is absolutely right that we're seeing in Spokane specifically, but in Washington State, the trend's looking different for us. That it's the 20 to 29 age group that actually has the largest number of suicides. So I want to share a little bit about the global picture, what this looks like for the United States, and then I'm going to talk about Washington State. So it was the 10th cause of death nationally. Remember, the 8th cause of death in Washington State, and it's a rate of, again, 14 people per 100,000. We had almost 45,000 people die by suicide in our country in 2016. By the way, we have about 800,000 to 1 million people in the world die by suicide every year. Okay? So this isn't just a US issue. And that's a death by suicide every 12 minutes. Worldwide, it's a death by suicide every 40 seconds. Okay. Again, veterans are very impacted by this. 23% of all deaths by suicide in Washington between 2010 and 2012 were by folks connected with the armed forces. They only make up 8.5% of our state population. This is where we really need to pay attention. Again, this is a public health issue, but it is not something that we start paying attention to in high school or college or with middle-aged folks or even our older clients. We need to start having this conversation in elementary school. Okay? It is consistently the second leading cause of death in our state for those aged 10 to 24. We've had youth as young as 5 die by suicide in our state and nationally. If you look at the CDC website, they give a breakdown of cause of death, and they have a statistical bracket from 5 to 9. In 2015, we did have 17 youth between the ages of 5 and 14 who died by suicide. Just curious if anybody is sitting here thinking, how do we know that a 6-year-old intentionally takes their own life? I'm just curious. Yeah, so there's this process called a psychological autopsy, and it doesn't just happen for youth. It happens for anybody who dies and the circumstances are questionable. And this is done by the coroner's or the ME's office. where they go out and then they interview people. They interview family members and friends and teachers and coworkers. And what they find is, even though we know that a 6-year-old doesn't understand object permanence necessarily, they don't understand that death is permanent, and that if they make this choice, they're going to go away forever. And these kids are still saying, I don't want to be here. I'm a burden. Nobody loves me. It would be better if I was gone. I just want to go away. So even though we know they can't understand their choice, they are still making the choice. Okay. So the impact of suicide in Spokane specifically, and the 2017 Emmys report just came out like 3 weeks ago. We had 122 people between the ages of 10 and 99 die in Spokane County by suicide in 2017. The interesting thing is, interesting not in a good way, is this is a fairly significant increase. It doesn't seem like going from 98 to 122 is that big of a difference, but it really is when we talk about people taking their own lives. And again, the largest number of suicides in Spokane County were in that age group of 20 to 29. What is going on for folks in that age bracket that this is, their #1 cause of death, other than natural causes? As recently as 2011, we had 70 suicides. So we've seen a pretty consistent upward trend in this. So I'm going to talk about some things we know about suicide. We know that 90% of people who die by suicide are experiencing mental health symptoms at the time of their death. And we know this, again, through that psychological autopsy process. Again, interviewing family, friends, coworkers, instructors, anybody we can gather information from. Inevitably, we find that folks are experiencing depression, the most prominent symptom. Second is anxiety, but we also see folks experiencing, schizophrenia and psychosis. That also leaves 10% of folks who die by suicide who don't have mental health symptoms at the time of their death. And just because somebody doesn't have a psychiatric diagnosis doesn't mean they're mentally well. There are a lot of people that never get diagnosed that live with conditions for a really long time. And comorbidity is one of the greatest risks. And I know several of you are heading into the medical profession, or you're going to be working in public health. So if you're working with somebody who is addicted to nicotine, who has COPD and diabetes, the more things compounding, the barriers in this person's life, the greater the risk for suicide. This can be somebody with an intellectual disability and schizophrenia. It doesn't have to be mental health specifically. It's just more than one thing going on at a time creates pretty significant risk. We know that contact with a healthcare provider does not confer protection. Referring back to Matt Adler's story, just because he went to the doctor doesn't mean people are being screened. And even if they are screened, it doesn't mean that anything is happening after they're screened. So in an attempt to always reduce stigma, after I had my daughter, I was diagnosed with postpartum depression. And I struggled with that for about 5 months, not really knowing what was going on with me. And I'm in the parking lot at work crying hysterically. And I call my provider and I say, I think I have postpartum depression. And she said, yep, I'm pretty sure you do. She was just kind of waiting for me to figure it out. She knew what I did for a living, and I worked in public mental health at the time, and she never asked me the question, never. And all of the screenings I had, post giving that baby. So I know that we're talking about maternal mortality next time. Women do die by suicide while they're pregnant and shortly after giving birth, and there's a lot of issues connected to that. Another story I'd like to share with you is a student I had in class about 4 years ago who came up during break and said, I'm actively suicidal right now. Okay, we're going to talk about that after class. Really what she wanted to express was how angry she was with one of our local hospitals, because she had been to the ER 4 times, like the last 4 nights before class. She wasn't sleeping. She was actively suicidal with a plan. And she finally asked the ER nurse the night before she came to class, why haven't you asked me if I'm suicidal? And the nurse said, because you don't look like you would be. what does that mean? What is because she was fully employed, she was articulate, she was working on a degree, and she was asking for help. She couldn't possibly be a person who's suicidal. So I just need you to understand that if you are struggling, or you have a loved one who's struggling and you say, hey, go to the doctor, and you think they're going to get screened, that is inaccurate information. So for those of you going out into the health world, please be part of the solution and start screening. 75 to 80% of people who die by suicide had non-psychiatrist physician contact within 6 months of death. So these people are being seen, and they're being seen relatively soon before their death. So chiropractors are doctors, and they have to have 3 hours of screening and referral once in their entire career in order to maintain their license. And they're not necessarily happy to have to sit in front of me to have this conversation. And most of the time those groups come in and kind of just collectively they say, we shouldn't have to have this education. We don't see these people. Of course they see these people. They're not asking the question. And by the end of that 3-hour training, typically 4 or 5 of them have said, well, yes, in fact, I've had a patient die by suicide. Okay, so how soon after you saw them did they take their own life? And the time frame has been between 2 days and 3 weeks. And I would argue that physical therapists, massage therapists, and chiropractors actually have more intimate relationships with their patients than primary medical providers, because they're working with us on pain, they're touching our bodies, where our GP doesn't typically do that. We also know that suicide risk is greater in survivors, and these are folks who've lost a loved one. There are 2 groups of survivors, people who've attempted and survived, and then those of us who are left behind when somebody takes their own life. So again, if you are working with people, especially kids, it's really important for you to know if they've had a parent or primary caretaker die by suicide, because suicide is contagious, and it's most contagious within that familial relationship. So no other risk factors for these folks. They're already at a 4 times increased risk for taking their own life. And if we think about that for a minute, it makes sense, because who are parents supposed to be for their kids? Role models, right? So we model behavior, right? I have one child, she's 9, and she thinks I'm super awesome, which is great. And I've heard that there's, that might last for a couple more years, and then there's going to be like a 5-year gap where, I'm not so awesome. But, if I were to do this right now, so mommy who's awesome and has all of her ducks in a row, because kids assume that parents know what they're doing, whether we know what we're doing or not. If mommy who is awesome and has all of these things going for her and has the answers to all the questions cannot make it in this life, how can I? We also see this contagion with celebrities. It's the same kind of messaging. If Robin Williams, who had everything going for him, cannot hack it in this life, and I've already just been hanging on, do I still have a reason to hang on? So we need to make sure that we are asking these questions and informing people of their risk, and then working really hard and proactively to enforce their protective factors and decrease their risk factors. Okay. We also know that asking the question can prevent a tragedy, and we know that collaborative treatment works. So I'm going to talk about the collaborative treatment piece first. Again, oftentimes the person who is struggling with suicidal thoughts, feelings, and behaviors are experiencing mental health symptoms. And a lot of us, again, would go to our general provider. We may or may not be put on medication. That is just one piece of the treatment picture. It shouldn't just be medication. And quite frankly, medication can create risk, and we need to be aware of that. But they should also have social supports that can help keep them safe. They should have therapy if that's what's needed. They should have good dental health. I don't think a lot of people are aware that poor dental health can actually create a lot of suicide risk. I don't know if any of you have ever had a toothache or an abscessed tooth. That can create a lot of pain, and actually that bacteria can then go up into your brain and impact your ability to think. So it shouldn't just be getting meds. It should be everybody working together as a team to help this person understand why it's important for them to stay here and offer them hope. So going back to asking the question, one of the pieces of pushback I often get when I'm training providers in the community is this is outside of my scope of practice. Asking somebody if they're suicidal is outside of my scope of practice. And I would argue it's not outside of the scope of anybody's practice. Any human being can ask another human being how they're doing. It can be really scary, especially if you are not comfortable having this conversation. But if we as professionals push back or seem reluctant to have this conversation, we are sending the message. Again, these are not feelings or thoughts you should be having. We re-stigmatize, re-shame. So we need to get comfortable asking the question. And then if the answer is yes, we need to be familiar with the resources so we can get people help. There is a wrong way to ask this question. I'm just curious if anybody happens to know what that is. Yeah, want to give it a shot?
Yeah, I think it's suicide, right?
Right, yeah, you'd never do that, would you? You wouldn't make a choice like that, would you? You're not thinking about killing yourself, right? What does asking it that way tell the person? Right, I super don't want to have this conversation, and please let your answer be, of course not. Yeah. I will tell you, I mean, I'm standing up here as the expert in this area. This question is much harder to ask in your personal life than it is in your professional life. At the time I worked at mental health, we actually had 4 nurses at Eastern State Hospital who died by suicide. And honestly, as a provider, those deaths were much more impactful on me because I worked with my clients actively to keep them alive. I mean, I knew that I was doing everything I could, but if it's Jane in the cubicle next to me, I have a great example of how I, as the expert, screwed this up. So my husband's best friend's brother attempted about 4 years ago. And while I was on the phone with her, I said, "You're not having those thoughts, right?" Because I really wanted that answer to be no, because it was personal. And it was harder because, I really wanted the answer to that to be no. And I had to, back up in my brain and then ask the question the right way, which is for age brackets about 10 on up, you want to see developmentally where they're at, is very direct. Are you thinking about killing yourself? Okay. The word kill crosses cultures. There's really no mixed message there. You could say, are you thinking about suicide? But suicide is the academic word, the professional word that we now use to describe this behavior. I had a student who was super excited that she'd done her first suicide risk assessment in her practicum setting, and she got to come to class to talk about it. And she said, it was the weirdest thing. I asked this lady if she had been suicide or if she was suicidal, and she said, hell no, but I think about killing myself all the time. So suicide meant one thing to her. Thankfully, we were able to get that information from her so, we could provide the appropriate resources. But, suicide means different things to different people. Are you thinking about killing yourself? Pretty much spells it out. Now, for the ages maybe 5 to 10, again, depending on what's developmentally appropriate, we want to ask questions like, do you ever wish you could just go away and never come back? Or that you fall asleep and you never wake up? So we can still ask the question. It may be not as direct as we would for folks at different developmental stages, but it's important to ask the question. And then again, if the answer is yes, to say, okay, will you please stay put while I find you some resources? Because depending on your scope of practice, it might absolutely be your job to then assess them for hospitalization or transfer them to, the mental health unit, or call the police, depending on what their level of risk is. You have to know, what your process is and how to get those folks help. Okay. So we have lots of resources available. They're not going to be, what's the word I'm looking for? Generationally, folks prefer different types of resources. So everybody's probably pretty familiar with the fact that we have a national suicide prevention hotline that anybody can call at any time. Veterans can call that line, and if they press 1, it specifically goes to our one and only dedicated veterans crisis hotline that's located in New Jersey. They do amazing work. We also have a text line that's been in place for 5 or 6 years, and younger folks tend to like this option better, where they can just text 741-741 and be communicating with somebody that can offer some assistance. So our local crisis line, First Call for Help, I did not put the phone number up here because it's changing as of January 1. I know, and I don't know what it's going to be. And this has been a staple in our community since, I think, 1970, so a really long time. So if you are working with folks who often access First Call for Help, we're going to have to do a lot of education about that new phone number. I know for the first couple of months, if they call the old number, which is 838-4428, they'll be directed to the new number, but at some point in time, they'll have to learn the new number. I have a couple of students who are actively volunteering at this I'm Alive chat line, where you can do online chat for hours if you need to get support if you're not feeling well, not necessarily just suicidal, if you're experiencing depression or anxiety, paranoia. And then if you work with the LGBTQ+ population, the Trevor Project is an amazing resource to direct those folks to. Okay. I'm keeping an eye on the time. I think I've gone through my content a little quicker than I had planned. All right. Whew, that was a lot of information in about 40 minutes. So we're going to move on to questions. And Jen is going to facilitate people who are online if they type stuff in. So who has questions? What do you want to know? Yes. Yeah. Press and hold.
You gave some stats for children whose parents had committed suicide.
Mm-hmm.
Do you have anything for siblings? I have 3 other children.
So if they've had a sibling die by suicide, is that specifically what you're asking? There are stats. I am not going to cite them appropriately from memory, but they do exist. One of the things, if you have any questions that I'm not able to answer today, if you want to email me, I am happy to get that information to you, because again, it is contagious. It's incredibly impactful. I was supposed to have a co-presenter today. Her name is Sabrina Vitava. I don't know if any of you are familiar with her. She actually had 2 siblings who died by suicide. Yeah, and is a great advocate for suicide prevention and education in this community. And I know that she does a lot of work around losing siblings. Absolutely. Thank you. Yeah, if you want to press and hold. So
I was wondering about the contagibility for parents whose children have committed suicide.
yes, died by. Yes, parents are incredibly impacted by that as well. We don't see the 4-fold increase that we see with children whose parents die. And by the way, that isn't just, you know, if I'm 7 and my parents dies by suicide. That's also if I'm 24 and my parent dies by suicide. So we see that across the age range if the parent dies. I think it's like a 2.3 increased risk. But of course, all data, depending on who collects it, can look a little differently. Thank you for that question. I saw another hand up. Yes.
So you mentioned a lot of social factors. I'm always curious about the genetic factors regarding depression running in families or bipolar. Yeah. I had a student who had depression but then realized she was starting to experience symptoms of bipolar. She lost a brother to suicide who also had that diagnosis. So I'm thinking, okay, is there more to it than just, not to say just, but right, environmental?
Yes. So one of the things I want to stress about suicide research is you will never see the word causal. You see correlation, you know, weakly correlated, strongly correlated. The current thinking about suicide is that there may be heritability there because we do see it run in families, but they don't know for sure. It's just like mental health conditions. So for schizophrenia, they've done studies with identical twins, and 48% of the time, if one twin has schizophrenia, the other twin has schizophrenia, but that also leaves 52% of the time where they don't. So, you know, we see potential, you know, that familial genetic link, and we also think that environmental factors are often more impactful on that. You know, this is also something that's not predictable. If you've done any of this work, you know that we have very nice, neat little suicide screening tools. Okay, and we often collect risk and protective factors. So you could have one risk factor and 40 protective factors and think about it all the time, and I could have the reverse and I never think about it. I mean, that's the one thing with this public health issue is we can't just drill it down to the numbers and say you will and you won't and you might, so I need to put these specific things in place for you. Yeah.
So you mentioned a lot of people who were to say, or not say, I should say, are you thinking about taking your life? Yeah, I know that's wrong, but as an SLP, or as I want to become one, let me just ask this. If you see your clients, they're progressing, but they seem to be, how shall I put this, angry at themselves or frustrated, or this, I guess, symptoms of they don't like this life anymore, is it your job to ask the appropriate question? I can't think of it at the moment. Or is that, or should you mention it to somebody else? Or
so can I clarify, when you say SLP, that means something really, okay, thank you. Because in my world in mental health, we actually have a program called SLP, which is the supportive living program, folks that are, so I know we have these acronyms that sometimes we don't speak the same language. So I would need to refer you to your professional code of ethics, because for social workers, the NASW code of ethics says if somebody tells you they're thinking about hurting themselves or somebody else, you need to do something. Now, that doesn't mean you fix them. That means you report it to whoever can provide assistance. Sometimes it's calling 911, sometimes it's calling first call for help, sometimes it's calling their medical provider. But we can't just be like, thank you, I'll see you next week, and walk out the door. So, sorry.
I just meant, like you said, some people aren't permitted to ask that question. I'm just wondering,
no, I said anybody should be able to ask that question, whether it's in a professional context or not. Yeah. No, everybody should be able to ask that question. Yeah.
When it comes to screening, is there a difference between asking someone verbally and asking someone like paper, right? Like there are lots of paper assessments.
There are lots of paper assessments, and that goes back to my, if somebody sees a primary medical provider, are they being screened? I know that some of our larger health conglomerates in Spokane have started to ask the question via paper. The medical profession often uses the PHQ-9 or the PHQ-2, and there's some questions about depression and some questions about suicide where people can check boxes. Now, what happens after those boxes get checked, I don't necessarily know. I think paper is okay as long as somebody actually looks at the paper, sees what they say, and then actually asks some follow-up questions. And even if the paper says no, if you're working with them and you just get a sense that things aren't okay, that you should still ask the question. So, one of the things I didn't talk about is how would we even know that we need to ask the question? People typically, and there's a really small percent of people who die by suicide that don't tell anybody, who just don't give any signs or indicators. That's a really small percent. Most people indicate to a loved one or somebody else within a week preceding to their death that they're thinking about it. But it doesn't mean me directly saying to you. It could be giving away things they love. It could be getting their affairs in order, which can be deceiving. We had a gentleman in Spokane whose story was very similar to Matt Adler, early 40s, happily married, successful career, 2 young children, who did the things that we're supposed to do in our 40s. He started to pay off his mortgage, and he paid off his student loans, and he paid off his car loan, and he got life insurance, and he bought a burial plot. And that was about 18 months of his life. And he, in fact, was preparing for his death by suicide. It was just harder to see that because it took so long. If you know somebody who just has sudden and frantic urge to get all of their affairs in order, that is one of the indicators that you should ask the question. Any change in behavior, if somebody has been in crisis and is suddenly magically better, they are not suddenly magically better. That typically doesn't happen unless they've had a urinary tract infection and they're about 3 or 4 days into their course of antibiotics, right? that is the one situation where people are like, I can think clearer again. Or, folks who have COPD or their blood sugars are a little out of whack. When some of those medical conditions are, in those maintenance levels, they might be a little, still not magic, it's just better. Saying things in my world especially was like, thank you, you've been very helpful. In the mental health world, clients didn't often say thank you, and they rarely said you've been helpful. So when they said, thank you, you've been helpful, in what way have I been helpful? Because I'm thinking that maybe you've just now made the decision to do this. I don't need to reschedule, I won't be around. So vague statements, all the way up to really direct statements that they're thinking about it and that they have a plan and access to that plan. I feel like that was a bit tangential, but we'll go back here and then over here. Yes.
Can you hear me?
Yes.
Is this going on? Okay. I have a question about some of the resources that you mentioned, about what an individual who accesses those resources experience. So I'm guessing like a big goal for a lot of them is just to have somebody to talk to that's outside of their circle or somebody that doesn't know their situation. And I'm sure they have the option of like being anonymous, but do any of these resources have like any type of follow-up, or do they connect them? Like what goes on when they contact them?
Yeah, so with the National Suicide Hotline, it is simply to have the conversation. Unless you're the veteran and you press 1, those folks, by the way, there's a fantastic documentary. It was put out by HBO about 5 years ago. It's actually called Crisis Hotline Veterans Press 1, and you get to see what they do. And that is all about, we're going to get you in. We want to sign you up for services. So it's not just de-escalating the crisis. They're following up to make sure that people are connected. Not all crisis hotlines do that. With First Call for Help, the initial screeners are actually volunteers and may have no education in the area of mental health. But if folks are suicidal, they get referred to people who are licensed mental health therapists or social workers who've been licensed for at least 2 years, and then they do resource referral and connection as well. Now, do those folks actually connect with those resources? I don't know that we have that data. If you've been in the hospital for a suicide attempt, you often walk out of the hospital with a discharge plan. Like, here are the resources you can connect with. There's usually not that warm handoff. Like, we're going to just physically make sure that you connect with another human being so they can continue to make sure you're okay. Actually, discharge, I think it's about the 2-day to 3-week right after hospital discharge, even for medical conditions, people are at really high risk for death, including suicide. The I'm Alive, it's just chatting with volunteers. They don't do resource referral as far as I know. I don't know if the Trevor Project does resource referral, but they have tons of resources on their webpage. And I think people have varying experiences. So for example, the Veterans Crisis Hotline gets such a large number of calls. They actually came under fire a couple of years ago because they were having to push so many of their calls off to a subcontractor, and then those subcontractors weren't necessarily answering their calls. So does that answer your question? Okay, and then over here. Push and hold.
Okay, sorry. So I've had people come to me and tell me that they are suicidal, and most of them, when they're experiencing depression, they don't feel that they have the energy to go out and do something else, go access these resources. And so I'm left with somebody has told me that they are suicidal. They do not want me to share. And I don't think that it is always a good thing to share when something is so serious as this. Like, I can tell somebody else, but then when they reach out, what makes that person accept that help and such. And so I don't know how to respond when somebody asks or tells me about this, and I've tried different things and I still don't feel that I am supporting these people enough. I've helped by being the listening ear and having them talk. I have referred for resources, and I have tried those ideas, but
Yeah.
that seems to still not be supportive enough, and I want more help.
Okay, so there's a two-part answer to that question. If you were having that conversation in a professional role, you don't get to not tell, and that's part of the conversation we have with our clients, right, is confidentiality only goes so far. If you threaten to hurt yourself or other people, we get to talk to anybody we need to, even if that's mom or landlord or your pastor, to make sure that you're okay. So that's the professional answer. And depending on your scope of practice, you may just be the person referring. Again, we can't make that person who's struggling actually accept that help, and we can't necessarily make the system engage with them. Yeah, on the personal level, it's so much harder because, again, you're not necessarily bound by confidentiality, but when I've had this conversation in my personal life, I've said, you know what I do, you know that I'm going to reach out to get you help. And maybe that's why they do talk to me, because they know I'm going to reach out for help. That is a really hard question to answer because every individual situation is different. And you're absolutely right. People who are experiencing depression don't even necessarily have the energy to act on their suicidal feelings. If it's a fellow student, through EWU, we actually have an anonymous student of concern form that you fill out, and then the dean's office and CAPS will actually actively engage that student. So you can step out of it at that point. I don't know if there's a similar process for WSU, and I don't even know if we have WSU. Okay. Okay. Yeah.
It's called the Aware Network for WSU.
Oh, okay, the Aware Network for WSU. Yeah, I will tell you that at times as a professional, I've also felt like I haven't necessarily been useful. I haven't provided as much support as I could have. And those things weigh on me. I know that's not a great answer. And just know that you are not the only person who's experienced that, either personally or professionally. It's like, what can I do? How can I help? Sometimes we feel a little hopeless and helpless ourselves about helping those folks access care. Okay, an online question.
So Raman, MPH student, asked, what do you suggest you do if you ask somebody if they're feeling suicidal or they want to kill themselves and they say no, but you still have concerns that they're not being truthful with you?
Yeah, so as a provider, I would usually just say, now you're saying all the right things, you're saying the things I want to hear, and I need to tell you that I am still uncomfortable. I am still worried, and these are the reasons I'm worried. And again, because this is my professional role, I am going to now do these things. One of the questions I often get asked is, well, what if we piss them off, right? What if we make them really angry? And I've actually had medical providers have this conversation. I'll share that with you in a second. But my mantra is better pissed off than dead, okay? Because if they're dead, we can't do anything about it. If they get pissed, they're alive. We still have the opportunity to repair that relationship. And even if we can't, they're still alive. But the conversation I've seen medical providers have around this is, you know, about half of the medical providers have said, we should absolutely be asking this question at every appointment. And if they say no, even though if we don't trust it, we push further. And then we've had about half of providers say, well, that's intrusive. And our patients are going to get really annoyed with us. And I want to maintain my really good patient-client relationship. And then these providers say, but we ask them if they smoke every time they come in, and that's a slower way to kill yourself. And for women, we are asked at every single appointment if we feel safe in our relationships. And this is literally life and death. I mean, it could be you're here 1 minute and gone the next. So yeah, if they say no and you don't trust it, you simply say, I still don't feel good. I'm going to do A, B, and C. And if they're pissed, that's okay, because they're still alive. Sometimes being angry is the thing that keeps them around. Yeah.
I've got a question about when physicians don't ask, like half. I had a conversation actually with a psychiatrist, and I asked him, why don't they? He said, they don't have time. They don't have time. They've got bam, bam, bam. I've got like all the patients in these rooms I got to get to.
Right.
And
If
all
somebody
know
says
that
yes,
it
if somebody
says
says yes,
that makes them very uncomfortable. They're not sure how to address it. And so what I'm also wondering too is if you heard or from a physician, are they worried about any liability? Because if I don't ask you,
Yes.
then I'm not going to know. And if something happens,
Yes.
I'm not liable for it.
Like 1,000 times yes. So, you know, the top 10 reasons to never ask somebody who's suicidal. This was actually collected by the QPR Institute of folks in Spokane who made these statements. And the two things from physicians were, I don't have time, and the liability issue. And the other was, there's no box on the form. Like literally there is no box. In my EMR, there is no checkbox for this. Therefore, you know, in the 7.3 minutes I get to spend with a patient, it's not on my rundown of things that I actually need to be asking. So therefore I don't ask because it's not part of my procedure. So those two things. Yeah, and this is, by the way, a question that you need to ask within the first 5 to 10 minutes, depending on how long your appointment is, with the person, because if they say yes, you then actually have to have some time to do something about it. You can't wait until the last 5 minutes. Although those of us who've worked in the mental health world have also had what we call doorknob confessions, where the person is literally on their way out the door and they have their hand on the doorknob and they say, oh, and by the way, I have been feeling this way. Like, okay, come back in, or I'm going to walk you down the hall to Bob, who can take over for me because we are not now going to leave you alone. Yeah. Question.
So it's, from what I heard you say, it's true still, or did Washington pass legislation that doctors are required to ask, or no?
They're
required to be trained.
They're required to have training. They have to have 6 hours of suicide assessment, treatment, and management training once in their entire career to maintain their license. It doesn't then say that they have to take that education back to their practice and do screening.
Okay.
Yeah.
Are there, so is that, so are you aware if there are other states that do have that legislation in place? I was screened by my general practitioner back in Wisconsin.
Okay.
So I'm not sure if it's like through my health system or
so
statewide.
I will share with you that I am geographically challenged. Like anything from the Dakotas on is just like this big blank for me. But I do know that there are a couple of states over there that have also done really innovative things. Washington State's still the most innovative when it comes to legislation.
Okay.
But there are, in Wisconsin, I know Wisconsin is in that gaping black hole of my memory, right? So they might be. Yeah, and I know that there's lots of tribal communities that have put pretty strong evidence-based, you know, culturally appropriate evidence-based practices in their community. The 3 tribes on this side of the state, 2 of them have declared a state of emergency because their suicide rates are so high. So we do see pockets. Now, again, from the legislative standpoint down, maybe people are just doing best practices. I would have to research that. Yeah. Yes.
There are practicing professionals who do not acknowledge anxiety or depression as real or a prominent part of clients' lives. Yeah. And I recognize they may have had training, but how can we work with doctors to really understand it is real and it's not laziness or...
That's a great question. And when you find the answer, let me know, because then I could probably make millions of dollars, right? So I'm teaching second-year graduate social work students right now, clinical diagnosis, like how to recognize, and then evidence-based treatment for that. And they keep asking questions about, well, when I send my person to a doctor, they're going to know this and they're going to prescribe, right? No, because doctors typically have 1 3-month psych rotation during their entire education. Unless they choose to specialize in this area, they really don't have a lot of skill, again, unless they've started on their own in this area. So how do we convince people depression and anxiety are real? That's make it a law that you, well, and again, the PHQ-9 is a form that's consistently used in the medical field, which does ask some questions about, you know, not sleeping and feeling depressed, and if you're feeling suicidal, like what do you do with that data, and how do we convince providers that that data is meaningful and that we should be doing something? By the way, I think the PHQ-9 is also pretty standard in screening women postpartum, but they ask questions like, have your sleeping habits changed at all in the last, I have a newborn baby, so of course my sleeping habits have changed. No, I'm not sleeping. I do know we have some specific maternity, depression screening tools, but they're not used by most folks. Yeah. So I'm sorry I don't have an answer to that question. I struggle with that within my own profession. The depression is absolutely real, anxiety is absolutely real, and it shouldn't just be fixed with medication. There's all of these things, adjunctive therapies. Yeah. Another online question? Okay. Okay, I think we have until 5:30. Let's keep going. I will talk about this all night if you guys let me. Yes.
I just have another question about, do you, off the top of your head, know any stats of the suicides, either nationwide or in Washington, that where they recorded that there was alcohol or drugs involved?
Oh, Washington State, wow. I spent the last 2 days reading the ME's report, so I should know this. Roughly, don't quote me, 13 of the suicides in Spokane were linked to opiate overdose specifically. There's probably more linked to, a broader range of drugs and alcohol. So I will tell you that it's about a 33% rate seen in emergency rooms that folks have drugs or alcohol on board within the context of their suicide attempt. Now, I want to specify that these are not people necessarily that have diagnosed substance use disorders. These are people that took drugs and or alcohol within the context of their suicide attempts. And when I worked at mental health, and I'm sure you saw this as well, that people who never touched drugs or alcohol would actually go out and purchase alcohol specifically to numb things and get liquid courage in absolutely the wrong way to then be able to attempt. So alcohol specifically and other drugs have been indicated. Pretty high correlation. Yeah. Can you push the button? I can't. Thank you.
I've got the information here about teens if people are interested in that. Sorry, I was just bringing up the document.
Sure. And is this Spokane specific or is it, okay?
No, it's teens in the United States that I guess, sorry, I was just looking for it. I didn't know you calling me right away. But that the risks are especially elevated for female teens, for suicide by overdose. Anyway, I'm sorry, I'll find this and I'll let you know.
So let's talk about gender disparity in method for a minute while you're looking at that. So girls and women attempt about 2.3 times more often than men. Men die by suicide about 3 to 4 times more often than women. And it's, men die more often because they typically, I'll say typically, use more lethal means. Although I will tell you in Washington State, men and women, boys and girls, firearms are their #1 method for death. Men and boys still use firearms more than women, but we are starting to use firearms more and more. But it's like 36% of the time women are using poisoning, which includes alcohol prescriptions, and men use poisoning about 11% of the time. And that's data from 2012.
I have these, if you're interested.
Sure.
This is from NIDA, the National Institute on Drug Addiction. Indicates that upwards of 400,000 young people, that's teens and young adults up to age 24, die of drug overdose annually, which is an increase of almost 250% since 1999. And most of these deaths were attributed to unintentional accidental overdoses, but further analysis indicates that teenage girls, specifically age 15 to 19, are more than twice as likely to die from self-inflicted suicidal overdose compared to males in the same age group.
Yeah. Yeah, I mean, we're seeing accidental overdose deaths for that age group specifically skyrocket. And then, within that, folks who are suicidal in that process. And opiates just in general carry a huge risk of accidental overdose just in and of themselves. Yeah.
I went to a workshop not too long ago about suicide in the media and how the media discusses it. And I was wondering if there's any sort of concerted effort to change that.
Well, yes, although the media is not paying attention. So if you go to, oh gosh, I'm sure it's the CDC site, but definitely World Health Organization, there have been media reporting guidelines in place for at least 15 years that says, please don't do these things. Please do these things. And one of the things they absolutely should do is provide resources. They don't just say, so-and-so killed themselves. Wah. One of the things they are absolutely not supposed to do is identify method. Okay, because then they see contagion in that type of method. Like, oh, he was able to die by suicide by hanging, so I'm going to try hanging. We lost the 2 folks from the Coeur d'Alene School District last year, and one of them jumped off the bridge. How do I know that? It's because the media consistently reported that he went to the bridge and in spectacular fashion, I think I actually saw those words in a media report, launched himself off the bridge. So they're simply supposed to say, we tragically lost this person to suicide. These are the signs for suicide. If you are struggling or if you've lost a loved one, these are the resources. That is how the media is supposed to be reporting this, period. And if you reach out to me afterwards, I can link you with those media reporting guidelines. And again, they've been in place for forever. Yes, and then we'll go up here.
Are there guides for how suicide is, guidelines of how suicide is allowed to, or I know that's really difficult with censorship laws, but like, is it allowed to be portrayed within film or media of that?
Nope.
And do you know if there's there's research about how those types of depictions influence people?
Yep. So how many of you are familiar with 13 Reasons Why? Yes. So it just got renewed for a 3rd season, which I don't get. So they're scrambling to produce research since 13 Reasons Why came out. I will tell you that we had 2, 1 Spokane youth and 2 Idaho youth the 1st season who specifically said, I watched 13 Reasons Why and that is why I killed myself. So, we have local evidence that that directly impacted whether they felt they could stay alive or not. Because during that 1st season, there was nothing about at the end of each episode or the beginning of each episode, hey, here's a crisis hotline, you can get help. It was never really talked about that there was help. They have, I believe, added that in the 2nd season. But no, there's no legislation about that. And my guess is there won't be, because that would then be a freedom of speech. This is my, dramatic presentation of this. Yeah. I saw a hand over here. Did I see it? Yes, sorry.
Can you speak at all to the difference between self-harm behaviors and suicide? Because I think sometimes there's maybe evidence that someone is self-injurious or self-harming, but I'm not sure how to handle that differently than talk about suicide.
In the DSM-5, for those of you who read it for fun, or you're forced to read it for class like my students are, in the 3rd section, it's diagnoses for further consideration, and one of those diagnoses is non-suicidal self-harm, because we are seeing a pretty significant increase in teens specifically, but it certainly isn't limited to just teens, who self-harm, who also identify, no, I'm not trying to kill myself. I am trying to distract from these kinds of things. I am trying to feel something because I don't feel something. So you have to ask questions about context. So I see you have lots of scratches on your arm. Tell me about that. What is that behavior doing for you? Not, that's bad, you shouldn't be doing that. Just gathering some information in a neutral way. And that's how you'll know, it's like, I'm trying to kill myself. Okay. We have youth who will burn the skin off their arms with pencil erasers who say, I'm trying to kill myself. We know they can't kill themselves that way, but we actually consider that a suicide attempt, because a suicide attempt is defined by any self-injurious behavior with any intent to die, whether it results in injury or not, is a suicide attempt. So asking those questions about, give me some context here. What's going on for you? What does the behavior achieve? And then we know whether it's suicidal or not. The treatment is still therapy and teaching different coping skills, those kinds of things, which can also be helpful for the person who's suicidal, but knowing what is prompting that behavior is really important. Yeah. Yes.
Yeah. Just because I actually have a friend who will do self-harm, actually is kind of a self-medicating so that she doesn't commit suicide.
Yeah.
And that was a real eye-opener for me. I was like, huh.
Yeah, because our pain receptors then go up to our brains and releases dopamine and norepinephrine and what's that other one? Not Oxycontin. That's a pharmaceutical. Yeah. Yeah. So, the feel good stuff in our brain, pain, we have that built-in thing in our bodies. You can tell that I am not a medical professional because I'm saying things like things and up to your brain and yeah. Yes.
Some people have suicidal ideations, and that's also like a thought of release of something that they can do. So some people find that empowering.
Yeah.
When does that become concerning?
It becomes concerning when they say, I now have a very specific plan and I already have access to my means, or I have a plan to access my means. It's one of the things in doing this work is if somebody is actively suicidal and you say, will you give me your means? And they just be like, sure, here you go. You don't trust that because people who are suicidal, their lives have often been drilled down to this really small hole where the only thing they feel like they have control over is whether they die or stay alive. Okay? So if they've moved to that, I have access to means, I have a plan, I know how I'm going to do it, we know that they've moved up that risk scale. And again, if they just readily turn over their access to means, we know that they have other things. They have backup methods. And asking them if they have backup methods is not implanting the idea in their head that they need backup methods. The other common misconception is if I ask the question, I'll put the idea in their head. No research has ever supported that ever. Yeah. What else? Yes.
So the military has had suicide prevention training for a while now.
Yeah.
And I've noticed that it's changing a little bit in that it's putting more emphasis on intervention. And I was just wondering, and it's like everybody has known for years to ask them directly,
right,
and to take them by the hand to a mental health care professional and everything. But is there data that supports that this works, and why aren't we using it more if so?
Yes, I couldn't tell you what the data is specifically, and the reason I know the answer to that is yes, is because what the military is doing has reached the level of being considered an evidence-based treatment, which means there's lots of research that shows that it's effective. And actually anybody who is a qualified trainer in Washington State who then goes out and trains all those professionals I talked about has to have 2 hours focused specifically on veterans. And the state highly recommends that you take what the VA system is already doing and just put that in your training and use that. So for all of the faults in the VA medical system, I want to give them a couple of kudos, because anybody who gets treatment in the VA medical system is always asked if they're suicidal, even if they were just seen 2 hours ago or 2 days ago. So they are screened continually. Now, what necessarily happens after they say yes, how they then access those services, I'm not quite sure. But their prevention programs, again, are showing to be evidence-based. The other thing they did, which unfortunately the American Psychiatric Association did not go through with, is they said, please change post-traumatic stress disorder to post-traumatic stress injury. I mean, think about that. Just changing that one word. Who wants to have a disorder, especially if that disorder was created by some sort of trauma in your life? So for folks in the military, that's job related. It's an injury. I got bit by a dog. That's an injury. I got in a car accident. I got it, that's an injury. I was sexually assaulted. That's an injury. I'm not now disordered because I've had these experiences. So they wanted that changed in the DSM-5, and the APA said, thank you, but no thank you. I know lots of people who work at the vet centers who simply don't even call it, they just say, you're having traumatic stress. They don't even say post-traumatic stress. They just say, let's talk about the fact that you are experiencing traumatic stress. Yeah, yes.
I was wondering actually about like the cultural change that's more peer-to-peer.
That's I can't, because I can't answer that. I think somebody who works with that population, and I could actually connect you with somebody who does that work day to day, who could probably give you much better information than I could. Yeah. Yes.
There are DARE programs in school for drugs. Are there any programs in elementary schools for this topic?
I'm going to take a deep breath because I've had personal experience with this. So my daughter is now 9, so she's in 4th grade. Within 2 weeks of her starting kindergarten, I was in her principal's office saying, "Hi, I'm Stacy, I'm Sophia's mom, and by the way, I do these things, and are you aware that this legislation was passed that you need to have education?" The legislation had already been in place for a year, and the principal didn't know. So offered, like, "Hey, I'm happy to come talk to your staff anytime." They didn't hear from him for 9 months. And then he came to me and said, "Hey, have you heard of ACEs?" And I said, "Do you mean adverse childhood experiences?" "Yeah, I have some familiarity with that. Would you come in and talk about ACEs?" So I did, and I slipped in some suicide stuff. And then I didn't hear anything for 2 years. And I just realized the reason I didn't push him is because I was trying to balance my relationship. You know, I'm a parent, and I didn't want to be that parent. But then he came to me and said, "We're going to have an ACEs parent education night. Will you sit in the back of the room?" And I said, "Sure. When are you going to come let me talk about suicide?" I just asked him flat out. There was this really long pause, and he said, "Well, I'm terrified to have this conversation." And I get that, but did you know in 2015 we had 17 youth between the ages of 5 and 14 who killed themselves? No, I didn't know that. And one of the parents of a 2nd grader came up to me that night and said, "My child is actively suicidal on a regular basis. What do we do?" So there are programs. I have those really fancy books sitting in my office. I don't know of any elementary school who has, in this state, that has those protocols in place. I'm just now with a colleague being funded by Providence Healthcare, working on a project in the Meade School District, just in the high school. And we met with those teachers for a town hall 2 weeks ago, and they said, "It's great that we're having this conversation, and why aren't you doing it when they're in junior high or elementary school? Because they come to us already at high risk." And I said, "Yep, I get that." And by the way, the reason we're in the Meade School District is Providence collects data, and that zip code has the highest level of self-harming behavior of any zip code in Spokane. And that's across the age range, which a lot of people find really shocking. Yeah. I wish my answer was yes. Unfortunately, like, we don't want to think about these kids. A lot of people don't understand that kids as young as kindergarten can think about killing themselves. Yeah.
I was impressed. Girl Scouts actually has a mental health mental health badge.
Oh,
that came out a few years ago, and I was like, "Yay, Girl Scouts!"
Yeah. Yeah. I think we have about 9 more minutes. Other questions? Yes.
I was wondering, you had addressed a little while back about things, issues around folks having plans and so on and so forth. In your experience, or could you speak to do folks have plans, but they're putting all their affairs in order, as you described with that one gentleman?
Mm-hmm.
Do folks go through those paces of putting all their affairs in order, but not necessarily consciously within themselves make the connection that what they're doing is preparing, rather that they're just doing that, and then all of a sudden they make this decision, or it occurs to them that that's indeed what they're doing?
Yeah, so one of the things, we talk about when we have this conversation is that ambivalence exists up until the moment of death, because suicide itself is considered a really impulsive act. So yeah, folks can kind of be plugging along, and then all of a sudden are like, "Oh my gosh, I need to do this, and these things are taken care of. So my protective factor, of worrying about the house being paid off and student loans being paid off is no longer a barrier to me following through." So I don't know that I can answer the question, like, do they subconsciously, are they not aware of that? I just know that for most people who attempt, it's, they've been living with some sort of condition. So a mental health condition, a substance use condition, medical condition, or maybe all three. And then something really small triggers their ability to manage these things. and kind of pushes them over what we call that threshold. And those things, by the way, are really simple things. It's called HALTs. Hungry, angry, lonely, tired, sick. 9 times out of 10, if I could address one of those things, the suicidal person sitting in my office was no longer suicidal, because think about it, you have COPD and then you get the flu. Your ability to manage that condition once you become sick, or oftentimes in our world, psychiatric medications are incredibly constipating, and people don't really feel well when they haven't had a bowel movement for 4 or 5 days. So I've been plugging along and now I don't feel well. I don't know about you, if I don't sleep well for a couple of days, my ability to use my crisis coping skills or coping skills at all, or even just have a nice conversation with another human being, kind of goes out the window. The other thing is becoming intoxicated. So maybe they weren't consciously thinking I'm doing all of these things, and then they decide to get really drunk one night. It's like, oh, perhaps I was preparing myself and now I cannot do good future planning. Nobody does good future planning when they're intoxicated, whether you think you do or not. It's just not possible. Yeah. Yes.
Okay, my last question. How under-identified do you think suicide stats are? I mean, people can get in a car accident on purpose and now it's an accident and things like that.
So I would say most suicide data is incredibly conservative because of the way that data is recorded. So the World Health Organization gathers data from, all over the world. Some of those countries report every 5 years, some of them every 25 years. Okay, so there's that. In the United States, it's the CDC who collects that data and then reports to the World Health Organization. And the CDC gets their data from emergency departments, coroner and ME's offices, and the Department of Defense, and that is it. So we don't necessarily know about the kids who are suicidal in school but never interact with a mental health professional or a medical professional. If I were to go home today and attempt, after we've had this conversation, and go to the emergency room and convince them that it wasn't an attempt, right? I don't get counted. Suicide by cop, was it or wasn't it, right? Single occupant, single vehicle accidents, again, opiates. If there's a bad batch of heroin in Spokane that's killing people, if I'm suicide receptive, I'm gonna go search that out. And if heroin happens to be my drug of choice and I don't wanna die, I use other things until that bad batch. Yeah. Yep. So, yeah, conservative. One of the things that Dr. Tressiter talked about was, the economic impact. And I'm in the ballpark. This isn't 100% correct because I don't have this completely completed to memory, but suicides cost the U.S. specifically $54.2 billion annually. That's a lot of money that could be going somewhere else. And that is calculated on mostly lost wages, medical costs, and productivity for folks age 10 and up. So they say that each death by suicide, again, for 10 and up, is worth like $1,435,527. Okay? And then suicide attempts, it's like 4.2 billion annually for direct costs. And then if you look at indirect costs for lost days at work, it's another 2.4 billion. So if we could keep these folks with us, right? If we put even 4 billion of that 54 billion into prevention, into plans in schools, we would be, and this is, if you want to work in policy, you have to speak numbers, because that's what, legislative action is built on. Am I getting bang for my buck? Yeah, we're getting a lot of bang for our buck, and we have people staying alive. Yeah. Yes.
Going off of that, I was just wondering why you think those stats are going up, or if you have any ideas as to why those are increasing.
Just in general, or for specific age groups? Yeah. Yeah. So really quickly, the other thing when we talk about survivors of suicide, so those of us who are impacted by people who have died, Survivors of suicide are often defined as just family member and friends, which of course leaves out coworkers and providers. 7% of the US population have personally known somebody in the last 12 months who's died by suicide. And this isn't Anthony Bourdain or Kate Spade, this is people in our periphery. So there's a lot of research that shows, increased access to things like opiates, increased access to firearms, the economy, poverty, people being more impacted by adverse childhood experiences and not having resiliency factors in place. So it's lots of environmental things that have been going on. Actually, they've been looking at since 1999 to about 2014 that things have just slowly and unfortunately incrementally edged up for all those reasons and more. Yes.
Is there research to indicate the relationship of social media usage to those increasing statistics?
Yes, it is ongoing. I should have invited my colleague, Dr. DePaulis, because she did her PhD dissertation on cyberbullying and its connection to media. So again, not causal correlation. So you asked social media specifically, right? Okay, because tech in and of itself, becoming a more tech-focused world, has also impacted people's ability to keep their jobs and be able to function in the world. So for those of us, my age who are technology immigrants, my job adapts a new tech modality and I don't know how to do it, I'm having to look for another job. We've also seen kids use Facebook live stream to live stream their suicides. We see people egging other people on, like, just go ahead and do it. So the ability to get negative messaging about, the world that people, especially teenagers, are trying to stay alive in are just so much harder because of all of the negative messaging they can get from other people. And if it's on social media, those folks cannot see the direct, like back in my day, if I was going to harass you, I had to do it face to face. Right? Or I had to use that telephone with a really long cord and hide around the corner from my mom to call somebody and say, I don't like you. Yeah, those kinds of things. So yes, we are seeing that again. Correlation, not causal. We have hit 5:30. This has been fantastic, guys. Thank you so much.